Uro Surgery Part 4 Treatment of renal colic. Most cases are treated as outpatients. Hospitalization for patients with severe colic with persistent vomiting, parenteral analgesics, NSAIDs as indomethacin and diclofenac, narcotic analgesics as opiates in resistant cases, antiemetics as metoclopramide. IV fluids are given according to normal patient's requirements if vomiting is persistent, forcing excess fluids during attack to flush out the stone, but if not, it increases the pressure in an obstructed system, leading to increased pain. Antibiotics if UTI is suspected. Treatment of renal stones, conservative medical treatment, prerequisites, small stone, less than 0.5 cm, 90% of cases can pass spontaneously, no evidence of back pressure effect, such as hydronephrosis, no distal obstruction, and no evidence of infection. Method: high fluid intake with or without diuretics, analgesics and antispasmodics, urinary antiseptics, regular follow-up to monitor stone descent, recovering any passed stone or gravel, whether by filtering urine or by voiding in a clean container, stone analysis allowing planing for future therapy and prophylaxis, extracorporeal shockwave lethotherapy, lithotripsy, as well, principle performed without anesthesia, except in children, high-energy shock waves which are focused from outside the body on the stone. After its visualization using X-ray or ultrasonic imaging, the stone is fragmented, passed out through the normal pathway. High fluid intake is maintained to facilitate the passage of gravels. Indications: already opaque renal stones, less than 2 cm, advantages: suitable for risky patients, non-invasive technique done as an outpatient procedure, and successful for most radiopaque urinary calculi. Uric acid calculi are radiolucent and may cause some difficulty. Contraindications: urological contraindications and non-urological contraindications. For the urological contraindications, presence of distal obstruction, fragments will not pass, large stone, more than 2 cm, except after debulking of the stone by PCNL, we're gonna go there, percutaneous nephrolithotomy. Renal insufficiency, kidney has no power to push the fragments, an acute episode of renal infection. Non-urological contraindications: pregnancy, X-ray exposure, and bleeding diathesis. Complications: transient attacks of hematuria caused by the passage of gravel, colicky ureteric pain during passage of fragments, ureteric obstruction from arrest of the fragments in the ureter, and finally, failure to fragment hard stones. Percutaneous nephrolithotomy, endoscopic technique to fragment and remove renal stones. Indications: stones more than 2 cm, urinary obstructive lesions, and S-wall failure. Contraindications: bleeding diathesis and during pregnancy, X-ray. Technique: contrast material is injected up a ureteric catheter to visualize the pelvic calcaeal system. A needle is passed to the pelvis, through which a guide wire is inserted. The tract is dilated over the guide wire to a size sufficient to accommodate the nephroscope. Stone manipulation: small stones less than 1 cm directly extracted through the sheath. Large stones are fragmented first through nephroscope by ultrasonic, laser, or electrohydraulic lithotripsy. After stone removal, a nephrostomy tube is left in situ for 48 hours to allow drainage of residual tiny fragments, urine, and blood. Advantages: very small endoscopic incision, 1 cm, minimal operative and post-operative side effects, short hospital stay, about 3 days. Complications: kidney bleeding, extravasation of irrigating fluid into the peritoneum or retroperitoneum, residual stone, fragments, and injury to adjacent organs such as the colon. Open surgery: 5 to 10% of patients will be candidates for open surgery. Indications: contraindications or failed S-wall or PCNL, percutaneous nephrolithotomy. Methods: pyelolithotomy. Definition: opening the renal pelvis and removal of the stone. Advantages: bleeding is minimal and it doesn't cause any damage to the renal parenchyma. The renal pelvis is reached by exposing posterior surface of the kidney as it's the most posterior structure. Nephrolithotomy. Definition: incision through renal parenchyma to remove a stone. Indications: difficulty in exposing the renal pelvis or when the stone is large and palpable through thin renal parenchyma. Pyelonephrolithotomy combines both the two procedures, pyelolithotomy and nephrolithotomy. Indications: branched calculi, partial nephrectomy. Indications: a stone is impacted in a hugely dilated lower calyx with narrowing of its neck. Nephrectomy. Indications: the kidney is not functioning provided that the contralateral kidney possesses a good function. Surgical access to the kidney. Do plain X-ray on the day of the operation to confirm the stone position. The patient is turned on his side, lateral position, with the diseased side upwards, and bridge in the middle of the table is elevated to improve the access. The kidney is exposed by an oblique lumbar incision of Morris. This is a muscle cutting incision that starts at renal angle and carried downwards and forwards parallel to and about 1 inch below the last rib. Muscles are divided, then peritoneum is peeled forwards. Incision of the perinephric fascia exposes the kidney. The stone is removed by incising renal pelvis, parenchyma, or both. Incision in the pelvis is closed. The wound is closed in layers, leaving a drain in the perinephric space. So we have a diagram. Renal stones. They are divided into less than 5 mm, no obstruction, conservative treatment. More than 5 millimeters, symptomatic. From 5 mm to 2 cm, S-well. More than 2 cm, PCNL. Staghorn, PCNL, plus S-well or open surgery. Treatment of ureteric stones. Conservative treatment following the same principles as for the renal stones. Indications for intervention: stones more than 5 mm, evidence of secondary infection, evidence of back pressure effect, persistent pain, and failure of conservative treatment. Types of intervention for the upper third, middle third, and lower third. For the upper third, we have stone less than 1 cm, S-well, with stone in place or stone is pushed up to the kidney by a ureteric caster, then S-well is used as in renal stone, but if the stone is more than 1 cm, open surgery. Middle third of the ureter, open surgery. This is a treatment of choice. Ureteroscopic extraction, it's dangerous and not advised. S-well, very difficult and not efficient. Lower third of the ureter, if the stone is more than 2 cm, open surgery. Less than 2 cm, fragmented and extracted by ureteroscopy. Stone is less than 1 cm, extracted by ureteroscopy. Ureteroscopy technique: cystoscopy to identify ureteric orifice. Fine ureteroscope is passed up the ureter under vision. Small stone, a wire basket passed through the ureteroscope and is removed under vision. Large stone, fragmentation by ultrasound, laser, or electrohydraulic lithotripsy under vision. Complications of ureteroscopy: perforation, avulsion, or stricture of the ureter and infection. Open surgery, ureterolithotomy. Indications: stones in the middle ureter, failed URS, ureteroscopy or S-well. Stones more than 1 cm in the upper ureter, stones more than 2 cm in the lower ureter, associated ureteric stricture, and finally contraindications to ureteroscopy or S-well. Operation: incision, stones in the upper third, lumbar incision as in kidney exposure, middle third and lower third above the level of the ischial spine, Abernathy's incision, a muscle cutting incision that starts above the anterior superior iliac spine, passing downwards and medially parallel to the lateral half of the inguinal ligament, lower part below the level of ischial spine, lower midline of Pfannstiel's transverse incision. Plain X-ray just before the operation is important. At any level, the ureter is exposed by extraperitoneal route. Peritoneum is not opened, but it's peeled medially. It's preferable to open ureter in a healthy area above the stone. The stone is removed by a ureterolithotomy forceps. A small ureteric caster, 6F, is passed downwards the ureter to check its patency and to exclude any stricture. The ureter incision is closed by fine 4-0 polygalactin or Vicryl suture. A drain is inserted and the wound is closed in layers. Treatment of urinary bladder stones, cytoscopic litholepaxy. Indications: stone less than 2 cm. Method: the stone is crushed cystoscopically, whether by mechanically or lithotrite technique, which is called litholepaxy, or by ultrasonic waves or electrohydraulic shock waves. Fragments are then lavaged cytoscopically to the outside of the bladder by iliac evacuator. Due to high pressure in bladder during voiding, stones less than 1 cm have no chance to stay in the bladder unless there is distal obstruction, as in stricture or prostatic enlargement. Open surgery or cystolithotomy. Indications: stone more than 2 cm, multiple stones, failure of crushing the stone in a diverticulum, thin wall so it's easy to perforate, presence of another pathology needing surgery. Steps: low midline incision or synostotial transverse incision. The peritoneum is peeled upwards. The bladder is identified by its trabeculated muscular wall and the presence of a plexus of veins over its surface. The bladder wall is held between two bladder forceps and opened. The stone is extracted and the bladder is inspected for any associated pathology. The bladder is closed in 2 layers with 2 to 0 polygalacton or Vickerel after insertion of a suprapubic tube or a urethral catheter. The prevesical space is drained and the wound is closed. Prevention of urinary stone recurrence. High water intake, especially in hot weather. Should drink a large glass of water before going to bed, and again if he wakes up in the middle of the night. The stone should be chemically analyzed. Restrict diet containing high crystals according to stone composition. Treating infections and other causes of stone formation. Follow-up of stone formers to detect early recurrences. Metabolic workup to know etiology of the stone. Serum calcium and phosphorus to exclude hyperparathyroidism. 24-hour urine collection for calcium, uric acid, oxalate, and citrate. And you have to bear in mind that a person who formed a stone is liable to develop recurrent calculi. Specific measures according to the type of the calculus. Calcium oxalate calculi. Alkalinize urine by citrates to inhibit crystallization of oxalates. Reduce food which is rich in oxalates such as chocolate, spinach, and tomatoes or strawberries. Uric acid calculi. Reduce food rich in purines as meat and organ meat, brain and liver. Alkalization of urine by citrates. Allopurinol, xyluric, 300 mg per day in patients with hyperuricemia. Inhibits uric acid formation. Ammonium magnesium phosphate, struvite. Aluminium hydroxide, orally. Restricts phosphate absorption. Long-term antibiotics. Eradicate urinary tract infection. Avoid indwelling catheters. And finally, increase urine acidity by oral administration of 1 gram vitamin C daily. Calcular anuria. Definition: a common, serious, and urgent problem in which there is arrest of urine flow, anuria, secondary to stone obstruction of the ureters. Etiology: bilateral, renal or ureteric calculi, stone obstructing the ureter of an only functioning kidney, the other is non-functioning, surgically removed, or congenitally absent. Clinical picture: stage of onset, attack of ureteric colic followed by anuria, colic may be absent. Stage of tolerance, urea and creatinine start to rise, still there is no urine output, colic disappears and there are no major symptoms or signs. Stage of uremia, renal failure, later, clinical picture of uremia will follow within few days. Investigations: lab, radiological, lab, blood urea, creatinine, and potassium elevated to variable degrees according to the time of presentation. Radiological, plain X-ray may show a radiopaque stone. Abdominal ultrasound reveals distended pelvic calcaeal system on the affected side. Treatment: it's a urological emergency, fixing a urethral catheter, then a trial of forced diuresis using 40 grams furosemide in 100 milliliters saline over 2 hours. Drainage of the obstructed kidney as early as possible. Under anesthesia, a cystoscope is inserted and a ureteric catheter is passed upwards the affected ureter, past the stone. If it succeeds, a large amount of urine is drained. If the site of obstruction is not exactly known, both ureters should be catheterized. If ureteric catheterization fails, do percutaneous nephrostomy under ultrasound or fluoroscopy guidance. It allows for urine drainage. After renal function improvement, the patient is investigated and diagnosed, and the stone is treated as mentioned earlier. It should be remembered that a large hydronephrotic kidney is usually not the site of acute obstruction, as it's oftenly non-functioning. IVU is contraindicated in cases of renal failure. Differential diagnosis of calcular anuria: acute retention of urine. In cases of anuria, the urinary bladder is empty and not palpable. To clinically determine the side of obstruction, it's usually the side of recent ureteric or renal pain and the side with renal tenderness or guarding. Following the relieving of urinary obstruction, the patient may have severe diuresis, passing several liters of urine per day, should properly replace the lost large amounts of fluid and electrolytes. Benign prostatic hyperplasia. Incidence: enlargement of the prostate starting at the age of 40 years. By the age of 50 years, about 50% of males have BPH. BPH is a normal aging process which affects most males. Therefore, also it's called senile prostatic enlargement. Etiology: The exact cause is not known, and it's suggested that hormonal imbalance between androgens and estrogens due to aging stimulates the transition zone prostatic cells to undergo hyperplasia. Development of BPH is dependent on the presence of a functioning testis with adequate testosterone production. Pathology, microscopic picture, hyperplasia of glandular, fibrous, and muscular elements. Gross picture, changes in the prostate. The prostate is not divided into lobes, and it's actually divided into morphologically and functionally different zones. Anterior fibromuscular stroma, peripheral zone, it's the origin of prostate cancer. Central zone and transitional zone, periurethral area, the origin of BPH. BPH starts by development of nodules which enlarge, compressing urethra and rest of prostate. These nodules later form the main bulk of the BPH tissue, and the remaining compressed prostatic tissue forms a sort of surgical capsule within which the adenoma, nodular tissue forming the BPH, is inoculated during surgery. If hyperplasia is more prominent on both sides of urethra, described as enlargement of lateral lobes, central and grows up, elevating the trigone, middle lobe enlargement, and finally in some cases enlargement may be trilobar. Urethral changes, the adenoma compresses the urethra, leading to elongation, narrowing, and angulation, making castration difficult. Urinary bladder changes, suffering from chronic obstructive uropathy in the form of hypertrophy, trabeculation, sacculation, and diverticular formation, doesn't empty completely, leading to post-voiding residual urine. Ureters and kidneys, later unilateral or bilateral hydroureter or hydronephrosis. Clinical picture, symptoms and signs. Symptoms including irritative and obstructive complaints. It may be asymptomatic, frequency and urgency. The usual early complaints at first mainly nocturnal, wake up 2 to 3 times by night to void. Later it becomes progressive and it occurs at night and during the day. Hesitancy, has to wait for a few seconds to start micturition, intermittent stream, internal dribbling, difficulty to start, maintain, and terminate micturition, weak and diminished caliber of urine stream, acute retention of urine may be the first presentation, precipitated by excess fluid intake, diuresis, constipation, cold weather, alcoholic drinks, cystitis, prolonged confinement to bed, unrelieved sexual excitement, and drugs such as diuretics, antispasmodics, and antitussives, very painful and needs urgent intervention. Chronic retention with overflow incontinence. As obstruction progresses, more residual urine accumulates until bladder becomes overdistended, may contain up to 1 liter urine. The bladder turns atonic and the patient involuntarily voids small amounts when the intravesical pressure exceeds intraurethral pressure. The condition is painless and the patient complains of incontinence. Hematuria, enlarged prostate, compressing prostatic venous plexus at the base of the bladder, leading to congestion, rupture of the veins, and finally gross hematuria. Symptoms of complications, bladder stone, cystitis, bladder diverticula, or chronic renal failure. Signs, evidence of chronic renal failure may be present, neurological examination to exclude neurogenic bladder, suprapubic mass, full bladder may be felt, the DRE, prostate, is felt enlarged, smooth and firm. Median sulcus is preserved and rectal mucosa can be moved over the prostate to differentiate it from the cancer prostate. The severity of symptoms doesn't necessarily correlate with the size of the prostate. Any attempt to strain leads to prostate congestion, more obstruction, and the patient has to relax in order to void. Commonest cause of neurogenic bladder is diabetic autonomic neuropathy. Investigations, lab, serum PSA, prostate-specific antigen to exclude prostate cancer. Normal value is from 0 to 4 nanogram per milliliter. Urine analysis, CBC, blood urea, creatinine, and electrolytes. Radiological flowmetry, maximum flow rate less than 15 milliliter per second is indicative of obstruction. Abdominopelvic ultrasonography visualizes kidney changes and measures post-voiding residual urine. IVU showing the following changes: smooth basal filling defect in the bladder, sacculation and diverticula, post-voiding residual urine, and hydronephrotic changes in the kidneys. Transrectal ultrasound or TRUS, assessing the size of the prostate and guide prostatic biopsy if prostatic cancer is suspected. Treatment, medical treatment and watchful waiting indications. Patients with minimal symptoms, watchful waiting, avoid diuresis, constipation, wind, unrelieved sexual excitement, and withholding micturition for long periods. Close follow-up with periodic flowmetry and symptoms score. Medical treatment: alpha blockers and 5-alpha reductase inhibitors. Alpha blockers, tramsulocine, block alpha receptors in the bladder neck and prostatic urethra to diminish outlet muscle tone to improve particularly frequency and flow rates. 5-alpha reductase inhibitors, such as finasteride and ductasteride, inhibit the enzyme 5-alpha reductase, which changes testosterone into the active dihydrotestosterone in the prostate. Those who improve on this treatment, it is continued for life. Minimally invasive procedures aim to relieve symptoms when drugs are not effective and while definitive treatment is not suitable or contraindicated as in high-risk patients. It includes ablation with microwave and radiofrequency or placement of a urethral stent. Definitive surgical treatment, the idea to remove the adenoma from inside the false capsule of compressed prostatic tissue. Indications: patients with marked symptoms, patients with complicated BPH as recurrent UTI, recurrent acute retention episodes, chronic retention with significant post-void residual urine, gross hematuria, bladder diverticula or stones, back pressure effects on upper urinary tract with renal impairment. BPH is a normal aging process which is not a disease by itself unless it causes obstruction. BPH and prostate cancer can be present in the same gland. Regular PSA evaluation for all men more than 50 years helps early detection of cancer prostate. When complicated, the treatment of BPH is usually by TURP, T-U-R-P, that we're gonna go later. So, the surgical treatment techniques, we have endoscopic transurethral surgery, which is the TURP, and open surgical techniques. Endoscopic transurethral surgery, transurethral resection of the prostate. This is the standard treatment using cystoresectoscope. The adenoma is removed transurethrally, piece by piece, using an electrocautery. Limitation: large adenoma, lengthy and hazardous procedure. Visual laser ablation of the prostate, VLAP, and transurethral heat prostatic vaporization. Open surgical techniques, indications for exceptionally large adenomas. Methods: transvesical prostatectomy and retropubic Mellon's prostatectomy. Transvesical prostatectomy indications: when there is an associated bladder pathology which requires surgery, such as diverticulum or big stone. Retropubic or Mellon's prostatectomy: the retropubic space is exposed and the bladder is not opened. A transverse incision is done directly through capsule of the prostate. Complications of the surgery: bleeding, the main problem, primary, reactionary, or secondary. Clot retention may occur. Retrograde ejaculation occurring in more than 90% of the cases. Cause: damage of the internal sphincter. Infection: urethritis, cystitis, or epididymoorchitis. Bladder neck fibrosis and urethral stricture. Urinary incontinence: true incontinence from sphincteric injury is rare, in 1 to 10,000 cases. Temporary urge and stress incontinence for a few days are common. TURP syndrome incidence: rare complication only with endoscopic resection. Cause: absorption of irrigating hypotonic fluid during endoscopy, characterized by hypervolemia, dilutional hyponatremia, and intravascular hemolysis. Avoidance: using glycine isotonic solution for irrigation. Bladder diverticula. Definition: outpouching of the bladder wall. It may be congenital, but most are acquired due to infravesical obstruction. Complications: ureteric obstruction, rare, and stones formed inside due to the stasis. Clinical picture: usually no specific symptoms indicative of the diverticulum. Symptoms are those of the obstructive cause. Double micturition and large diverticulum mechanism: the diverticulum fills with urine during micturition and then empties into the bladder. Immediate desire to pass urine for a second time. Complicated diverticula, frequency, pain, and hematuria. Diagnosis: cystoscopy, ascending cystography, and finally IVU to confirm diagnosis and to determine the cause. Treatment of the cause: diverticula are not excised unless they are complicated. The operation is usually done in the course of surgery for distal obstructive lesion with prostatectomy, under the principle of don't trouble the trouble until the trouble troubles you. Urethral stricture. Etiology: post-traumatic, the most common cause. Post-gonococcal infection affecting bulbar urethra in 70% of cases. Incidence: usually in young active males, rare in females. Complications of obstructive uropathy as back pressure changes, infection, stone formation, and renal failure. Secondary infection with periurethral abscess formation, spontaneous rupture or drainage leading to urethral fistula. Clinical picture: difficult micturition. Patient has to strain to pass the urine. In contrast to BPH, the stream is thin and weak, terminal drippling as urine trickles from dilated proximal urethra, urethral discharge because of infection, frequency due to incomplete bladder evacuation or cystitis, acute retention precipitated by excess fluid intake or by activation of local infection, chronic retention in long-standing cases and causes bladder fullness and possibly dripping due to retention with overflow. Investigations: uroflowmetry reveals obstructed flow characterized by straining. Ascending urethrography detects site, length, and degree with the shape of stricture. Urethroskopy to see the stricture and assess its possible treatment. Sonography to assess the upper urinary tract, and IVU to assess renal function and back pressure changes. Treatment: endoscopic visual internal urethrotomy through urethroscope and under direct vision. Stricture is visualized and emphasized with a sharp knife blade, followed by regular dilatation. Surgical urethroplasty indications: bulbar and penile urethral strictures if previous measures fail. Idea: exercise fibrous tissue of a stricture and do end-to-end anastomosis. If the stricture is long, a tube or a flap constructed from penile, skin, scrotum, or perineum used to replace the narrow segment. Tumors of the urinary tract: renal neoplasms, we have benign or malignant, the commonest. Primary, secondary. Primary, divided into parenchyma in 90% of cases and in pelvis 10% of cases. Parenchyma: renal cell carcinoma, hypernephroma, and nephroblastoma, which is Willem's tumor. Pelvis 10%, transitional cell carcinoma, and squamous cell carcinoma. Renal cell carcinoma or hypernephroma incidence accounts for 75% of all primary renal neoplasms. Male to female ratio is 2:1. The majority of patients are 40 to 60 years old. The tumor is usually unilateral, bilateral in 2 to 3% of cases. Etiology: smoking increases the risk twofold, then hepalindo disease, higher incidence. There may be renal and pancreatic cysts, retinal angiomas, cerebral hemangioblastomas, and pheochromocytoma. RCC or renal cell carcinoma in these patients may be multiple and bilateral. Deletion of the short arm of chromosome 3. Pathology: gross appearance, commonly starting in one pole of the kidney. The tumor color is golden yellow due to its high lipid content. Areas of hemorrhage and necrosis are common. There is an apparent false capsule surrounding the lesion, but the tumor actually invades the adjacent tissues beyond it, infiltrates the renal pelvis early in the course of the disease. Microscopic appearance: adenocarcinoma, cells of origin, proximal convoluted tubules. Types of cells: clear cell pattern, the majority, as the cholesterol crystals in the cytoplasm are dissolved during preparation. Granular cell type, due to increased number of mitochondria. Spread: direct, early to renal pelvis, early and common occurrence of hematuria. Lately invades renal capsule. Perinephric fascia, adjacent organs may invade and grow inside the renal vein, then IVC. Finger in glove, leading to secondary varicocele. Lymphatic to lymph nodes along the hilum of the kidney and then to the para-aortic nodes. Blood, giving rise to metastasis to the lungs, bones, and brain. Staging: T and M staging. T for the primary tumor. T1, tumor less than 7 cm limited to the kidney. T2, tumor more than 7 cm limited to the kidney. T3, tumor extends into major veins or directly invades adrenal gland or perinephric tissues. T4, the tumor invades beyond Gerota's fascia. N, regional lymph nodes. N0, no regional lymph node metastasis. N1, metastasis in a single regional lymph node. N2, metastasis in more than one regional lymph node. M, distant metastasis. M0, no distant metastasis. M1, distant metastasis. Clinical picture: hematuria, pain, renal mass, metastasis, non-specific symptoms, secondary varicocele, and systemic. Hematuria in 50% of cases. Characters: painless, recurrent, profuse, total hematuria. Sometimes blood passes as tubular clots taking the shape of the ureter. Pain in 40% of cases due to stretching of the renal capsule by the neoplasm, passage of blood clots causing ureteric colic, and infiltration of adjacent lumbar nerves causing referred pain. Renal mass: irregular hard renal swelling, felt in 30% of cases. Metastasis may be the first presentation as to pulmonary or bone. Non-specific symptoms: fever, night sweats, weight loss, or anemia. Secondary varicocele, rapidly enlarging and doesn't empty by scrotum elevation. Systemic paraneoplastic syndromes, hypercalcemia in 5% of the cases due to secretion of the parathormone-like substance by the tumor or due to presence of bone metastasis. Polythysemia due to excess erythropoietin secretion by the tumor. With the wide use of imaging modalities, many RCCs are detected incidentally, and the classical triad of hematuria, pain, and renal mass is present in only 10% of the cases and indicates advanced diseases. Investigations for diagnosis: CT scan. This is an investigation of choice. It's accurate in detection of exact size, site, and consistency of the lesion, invasion of the renal capsule or any surrounding tissues, lymph node enlargement, and invasion of the renal vein or INC. IVU may reveal enlargement of the kidney, elongation, displacement, compression, or amputation of the calyx, displacement of the whole renal pelvis. Renal sonography: it shows the tumor as a solid mass. For staging, chest X-ray and isotope bone scan detect metastasis. Treatment: localized disease and advanced disease. Advanced disease, unfortunately, RCC is a chemoresistant and radioresistant, so patients who have metastatic disease may receive targeted therapy, new drugs targeting angiogenesis, or immunotherapy using alpha interferon or interleukin-2. Localized disease, surgery is the only treatment which may achieve cure. It consists of radical, open or laparoscopic or partial nephron-sparing nephrectomy. A prerequisite of removing a whole kidney is to ensure that the contralateral one is adequately functioning. Radical nephrectomy entails removal of the kidney within its sheath of Gerotis fascia. It's recommended to expose and ligate vascular pedicle as a first step of nephrectomy for preventing dissemination of malignant cells during manipulation, to have good control over a very vascular tumor, and finally to be able to remove a malignant thrombus from IVC if present. And this concludes our part for the urosurgery for today.